Thank you very much. Merci à vous. Thank you to the organisers. It's such a pleasure to be here. I love coming to Canada. Thank you. And it's such a relief to be here. For a long time, I didn't believe that I would actually be allowed to come at this moment. Before I begin to speak, I would like to acknowledge my co-authors, Vincent Delhomme and Alex Fife, and also the COVID Lex Atlas, a couple of the editors of which are in the room, who commissioned me and Sabrina Rodger-Wirtz to write the entry for the European Union. If you want to know more about the COVID Lex Atlas, please ask me about it at lunchtime. So my essay question, as it were, was what did the European Union do in terms of border control during, or what is the European Union still doing in terms of border control during the COVID-19 pandemic? I'm just going to begin by saying a few things about what the European Union is and isn't. So first of all, it's really important to say always that the European Union is not a state. It's not directly comparable to a federation or a federal state. What it is a deeply integrated regional trade bloc. And most legal and political science commentators agree that it's now more than that. So the depth and the breadth of integration of the European Union member states suggests that the European Union is some kind of quasi-constitutionalized entity. That means that as lawyers, we can hold the European Union to account as if it had a constitution, while at the same time recognizing that it does not have a constitution in the sense that a state or a federal state has a constitution. Some of the key characteristics of the European Union as a legal entity include a profound reliance on law and a profound reliance on rule-based modes of operation. And I think that has important implications when we think about the European Union's COVID-19 response. The Union is also deeply committed to economic openness, free and fair trade, including all factors of production, not just capital, goods and services, but also people. And the European Union also is characterized by much greater than other trade blocs attention to the position of human beings, especially European Union citizens, but actually all human beings, as individuals with innate dignity, not merely as economic actors. So those are my sort of introductory remarks about the nature of the European Union. Turning now to the European Union's law on borders. And of course, within the European Union, we have to think about two different types of borders. This is specifying even more from the introductory comments that we had about the different levels of bordering that Colleen talked about. So within the European Union, we have internal borders between the European Union's member states, and we also have the external border around the edge of the EU, as if it were that shape. It's kind of, I don't know, I need to practice doing that in the air. It's like making the actual shape of the edge of the European Union. So in principle, the European Union's legal order aims to secure open borders within the EU and a single border at the edge of the EU, in principle. And that in principle statement hides a massively complex set of border rules and practices. The law of the European Union's borders, both its internal and external borders law, has changed significantly over time. It continues to change. It differs significantly depending on which factor of production you're talking about. So borders for goods and services are more open than borders for capital or people. And it's characterized by non-hierarchical relationships between the European Union's legislature and executive and judiciary, and the legislatures, executives, and judiciaries of the European Union member states. So it's not a hierarchical relationship, and it's a complex and constantly changing relationship. In the chapter, of course, I'm focusing only on European Union law on movement of people across borders, and I'm not focusing on things that the European Union did, for example, to try to secure supply of PPE or vaccine supply. I'm thinking about human beings, and I'm thinking about the law at the relevant time, so from the start or just after the start of the global pandemic going forward. And what the chapter does is, one more introductory comment. This is, I'm not so good at doing it on screen. I usually have pieces of paper in front of me. So the other introductory comment is to say that the European Union's competence, so its formal legal power, is limited. In principle, the competence resides with the member states, and it's only the competence that's given to the European Union that the European Union legally has. So the European Union has partial competence to regulate migration of people over its external borders, and it has greater competence over internal border control. So what the paper does is it outlines key European Union COVID-19 border control laws and policies, and it describes their content and their features. That's what's in the body of the paper. And then the analytical part of the paper, which is the part that is the least developed in the draft paper that my colleagues have been able to see, that considers how we might assess that law from the point of view of broad public health perspectives. And of course, there isn't a single public health perspective from which we could analyze the performance of any legal order. So of course, what I have to say is to some extent idiosyncratic and certainly contestable, because it's based on my understanding of what a public health or public health perspectives might be. So there are 4 key features. How am I doing? Oh, good. Yes, I've got time to outline 4 key features. 2 minutes for each feature. Just going to the relevant bit. So the summary of the key features are: the Union's COVID border control was based on soft law. It was based on technocratic forms of governance. When I say was, I mean is, because of course this all continues. The pandemic's not over. It is focused on, and I was going to say obsession. I can say that verbally. I won't say that in the written paper. It's focused on an obsession with opening or freedom, and it is based on a distinction which doesn't necessarily make a lot of sense between internal and external borders. So in terms of the first one, the EU's initial responses and the European Union, the vast majority of the European Union's governance of the pandemic took the legal form of soft law. The Union's institutions relied on communications, guidelines, recommendations, technical scientific guidance of European Union agencies, particularly the European Union's Agency for Disease Control, the ECDC. The Union's ECDC was the body in charge of collecting, evaluating, and disseminating relevant scientific data, providing scientific opinions, assistance, and exchanging information and best practice. The European Commission also tried to coordinate scientific advice through a scientific advice platform, which brought together advisors from national governments of the member states. That platform has been meeting once or twice a month since November 2020, although I think the meetings, I need to check, they tailed off more recently. So that approach is very much classical international law. It's like what the World Health Organization does. It uses statements of good practice. It shares recommendations based on comparative data to steer member states towards particular behaviors. And this is totally different from the European Union's normal law of border control on human migration. The EU's ordinary border control law is based on hard law, and it involves the European Union's legislature and its judiciary. It doesn't involve only soft law in this kind of international mode. Now, the public health implications of a soft law approach are very difficult to measure, and we've started talking about that already today. On the one hand, the European Union's approach meant significant and irrational variance in border control within and also into the European Union. On the other hand, soft law leaves significant discretion at national or even subnational levels for member states to develop their own border control laws and policies, taking into account their particular needs and populations, variations between different stages of economic development, the different resources that their national health systems had, and so on. The European Union's approach here to use soft law meant that nothing was done within the legal powers that the European Union does have to tackle the irrationality and the disproportionality of European Union member states' border control laws. But then, given that, as we've just heard in the last panel, border control is only an effective, proportionate response to a global pandemic if it's accompanied by other measures and if it has certain modalities, and given that the European Union itself has very limited competence to adopt those other types of things, perhaps we should forgive the European Union for the effects on public health of its soft law approach. It wasn't the European Union's responsibility if that approach is deficient. Wow. Secondly, the European Union's approach is based on technocratic or scientific decision-making, and that is a kind of normal mode of governance for the European Union. The EU produced its own notions of the science, disseminated those among the member states. And of course, in the context of the pandemic, the science was highly contested. Again, we've heard a lot about that. The European Union didn't operate entirely in a vacuum. It worked both with the World Health Organization and with its own member states in gathering and analyzing data and then developing policy recommendations from that data. But it allowed more latitude than usual to the risk assessments of its member states. So in this way, the European Union was able to portray its border governance as legitimate and even depoliticized by decision-making relying or residing with technocratic agencies. Even though, of course, actually the European Union took very many politicized decisions in response to the pandemic, including, for example, its COVID-19 digital certificate, the vaccine passport that was developed. So this aspect of the EU's approach is consistent with its temptation, its tendency to articulate certainty and to articulate a European scientific certainty, even where it's not present. And it raises questions about how responsive the European Union's COVID border governance is to political or ethical concerns. And I think that public health governance includes its ethical and political dimensions. Yep, I see the time. It's not purely a technocratic undertaking, even if such a thing were possible. So the Union's depoliticized portrayal of its COVID responses obfuscated the political choices and the ethical choices that the European Union made, and it left almost no space for discussion of the ethical dimensions, and especially not through legal processes. And of course, legal processes in a constitutionalized legal order are supposed to be a space for holding executives to account. I have a third point about focus on freedom, but I'm going to finish with my final point, which is the European Union's response focused on opening internal borders at the expense of closing or keeping closed external borders. So it was put very, very explicitly. The European commissioners, Johansson and Reinders, said it in February 21. The European Union supports the member states' choice to be strict when it comes to travel to the Union while maintaining the necessary mobility within the Union. Now, you could write a whole paper pulling apart that statement. Wow. I mean, just wow. So this characterization of internal mobility as necessary is extremely revealing. It bears little resemblance to public health indicators. Differential treatment in EU law of its internal borders and against its external borders, that's already very well established and widely critiqued in European Union law, for example, in response to the so-called migration crisis. So the Union's COVID border laws perpetuated existing differential treatment of different types of human migration into and within the European Union, instead of considering the inherent dignity of all migrant human beings present within the EU or seeking to come to the EU. And in this regard, I think we can consider the EU's response as deficient. Thank you.
Thank you so much for this insightful presentation and for keeping with the time. Our next speaker is Professor Brenda Wilson. She's online with us, and she will present a conference entitled Public Health Evidence for Provincial Border Management. And Professor Wilson is a professor and associate dean at the Community Health and Humanities at Memorial University. So, Professor Wilson, la parole est à vous.
Thank you very much. Bonjour tout le monde. So I'm not far away from you, but I have had to unexpectedly put up a border of my own, for which I apologize. I'd like to be very clear that I'm speaking as an academic public health physician and as someone who has an interest, because I'm a resident in Newfoundland and I was an expert witness in the case that I'm going to discuss. What I'm largely going to do is unpack public health thinking through the court's analysis and decision making, and that will be how I approach this topic today. So for those who don't know, Newfoundland Labrador is out there in the east. It's a very large land mass, but with a very small population spread across the landmass. It's partly island, but it also has a long land border with Quebec, and it has a number of distinct Indigenous communities. It has its own Public Health Act, the goals of which are pretty typical to protect health, promote health, and promote health equity. And in introducing the legislation, the Minister of Health very much drew a clear line back to the influenza pandemic of the early 20th century, which was very important for the province. And in late 2018, his words could not have been more prescient. So of particular interest today is this section of the Public Health Act, which gives the Chief Medical Officer of Health powers under a public health emergency, and particularly these ones that relate to travel restrictions. In the pandemic, the beginning of the pandemic rolled out in Newfoundland, Labrador, the same as everywhere else, I think. We had a very large cluster very early centered around a funeral home. It was the biggest cluster in Canada at the time, but after that, the control was really very good. And you will see as of mid-May, the province was really ramping down restrictions, and we even opened up into the Atlantic bubble and had this kind of free movement, relatively speaking, with other Atlantic provinces by July. But the entry restrictions were a part of making that happen. And that basically you could only come into the province if you could show you were already a resident, or if you fit one of the exemption categories, or you were granted a special exemption in advance. So these came into force at the beginning of May 2020, and before the month was out, a court case had been launched by a woman who had been denied entry into the province to grieve with her family and help arrange her mother's funeral. Now, she was quickly granted an exemption after appealing, but she claimed essentially that this section, these measures were not under provincial jurisdiction, and that this denied her charter rights to mobility and liberty. So these are the questions that were addressed by the court, and the ones I've highlighted are the ones I'm focusing on. And here's the short answer to the decision, which came down in September 2020. The province had jurisdiction. Yes, her rights were actually violated. Her rights to mobility were violated. But yes, that this infringement was justified. Now, I'm not going to say very much at all about the analysis, the court's analysis of the mobility right, but there were some things that struck me particularly as someone who's not a legal scholar. The court tied this right to mobility very explicitly to dignity, to Canada's human rights obligations, and also these articulated that these reflected the essence of nationhood, that building Canada as a nation required the mobility right, the simple right of mobility. But to go to the main discussion today, it was about jurisdiction, and it was about why was it right to be able to infringe this right? Why was it legitimate? So as Colleen said right up at the beginning of today's conference, that powers over public health don't reside exclusively with either provinces or with the federal government. They actually have to work together to protect public health. In examining the various powers, the court actually, in relation to this specific legislation we're talking about and these powers that were enacted in Newfoundland, the court kind of worked through the various possibilities and actually rejected the federal powers that could apply. And perhaps surprisingly to some, also concluded that the provincial jurisdiction over healthcare also did not apply in this case as well. And actually that the measures, the public health measures that were implemented actually fell under other aspects of provincial jurisdiction. But what justifies overwriting the right to mobility? So the analysis, as you would expect, addressed what was the purpose of the measures, what was the objective, and were they proportionate? So I think this is where we start to get into where the public health evidence came into the picture. And a really important point that was made by an expert witness and was accepted by the court was that the purpose of the restricting entrance to the province was not to restrict travel. It was to protect the population's health by reducing people coming in who were carrying the virus. So it was about public health and population health. And that actually it didn't matter that at that point, Newfoundland and Labrador was really controlling the pandemic very well. It was about preventing it from falling off a cliff. It wasn't about responding to an already serious situation. So it was proactive and preventive. A number of contextual aspects were considered. I think everybody would agree, and the court certainly did, that this was a very serious situation under the situation of the pandemic. The court demonstrated a clear understanding of exponential transmission and what that implied, and that this was a vulnerable population facing what was a very serious potential health threat at that time, 2020. Newfoundland Labrador enjoys incredibly poor health. It's on average an older population than the rest of Canada, and across a whole number of chronic conditions, if 10th is the worst, it's down there competing to be the worst in Canada, unfortunately, for a number of reasons, which go back to social determinants of health. And the health system has been under stress for a long time, and there was a concern that it would not cope with the burden that the pandemic would put on it. The court considered all of the other measures that could be put into place or were already being put into place, and how effective they were, how practical they were, and the capacity to put these into place, and actually concluded that either individually or collectively, it could not be guaranteed that they would be as effective as the travel restrictions that had been, the very severe travel restrictions that had been imposed. Central to the analysis was actually predictive modeling. And you can't prove a counterfactual. We don't know what would have happened without the travel restrictions. There was no direct empirical data. It was impossible at the time. So the modeling became really important. And the results of two very different approaches, methodological approaches to predictive modeling, were presented. Now, I'm not going to talk about technical aspects of this, partly because I'm actually not qualified. The point is that by doing it in two very different ways and coming up with effectively the same results, that without the restrictions, it's highly likely that there would have been a huge increase in infection rates and transmission in the province, and it would have turned it from a controlled response to the pandemic to widespread community transmission. That was accepted based on the modelling. The court essentially said it's a no-brainer that the travel restrictions were much less of a harm than the benefits to controlling the pandemic for the population. That was essentially the response to it. But then there was a really interesting analysis of how far should the court go in trying to rely on its own capacity, or how much should it defer to public health expertise in its analysis. It noted that it was the legislature that had given someone powers to enact these measures and had judged the person, the Chief Medical Officer of Health, as qualified to do this, to make these decisions. So although there's no way that you cannot examine this, that you really actually have to think about the expertise and the powers that were already granted. So Dr. Janice Fitzgerald, the Chief Medical Officer of Health, started off the pandemic as an acting Chief Medical Officer of Health. She'd been in the position for a pretty short time. I think it's not surprising that she became the permanent incumbent some way into the pandemic. And essentially, the judgment was made that she was qualified, she had the expertise, and she was supported by an expert team, and that it was highly appropriate in this context to pay attention and give a lot of weight to what they judged was appropriate. The precautionary principle came into the discussion quite a bit as well, and into the analysis. And it was accepted, and I'll come back to talk about this in a moment, it was accepted that under this situation, the precautionary principle applied. And I don't know that there's many people who haven't seen the clip of Mike Ryan talking about this, but this was actually also entered into evidence. It's about, you can't be perfect, you have to be fast, and you have to not be afraid. So, you know, reflecting on this as a public health physician particularly, I think there's some important messages there about, you know, this complementary powers, federal and provincial, and the importance of everybody working together. By framing the decision-making of the Chief Medical Officer of Health as medical decision-making, and framing population health like the health of a patient, that's something that's very, very familiar to public health physicians, that kind of thinking, but it then certainly draws out some other implications around responsibility and accountability for decision-making, which I think not just in terms of travel restrictions, but more generally, that's something that deserves a little more thinking about. There was a very, very thorough examination of the competencies required for public health practice, a recognition of this as a medical specialty, and of the core competencies that were articulated after the SARS pandemic in Canada. And I have to say that the Creever report and the consciousness of the precautionary principle and how that played into the conclusions of the inquiry into tainted blood system in Canada was very prominent in the decision as well. Back to modelling. So, as I said before, the modelling suggested that the travel restrictions over the period of time concerned probably reduced COVID-19 cases by 90% in the province, which is substantial. But the point has been very strongly made, and was made in the case, that you have to approach predictive modelling appropriately. What worked for a small province with a very low transmission rate at that point would not work in other contexts. And similarly, you couldn't just take other predictive models and apply them to this particular context. So you need the expertise and you need to understand how modeling is going to be used. And I think it opens up a question, because I think we have all seen, especially in the early days of the pandemic, competing predictive modeling approaches. So those who are going to use the results need to understand and be advised appropriately, and not just kind of be in awe of the ability to quantify and to apparently predict. The travel restrictions were modified in July 21, in light of vaccine passports, essentially, and so they were opened up. And then as of March this year, the province completely opened up, and our Premier has been actively inviting everybody to come on in and just enjoy what we have. I shall reserve my comment, my judgment on the wisdom of that, but that's where we are now. So thank you very much.
Thank you very much, Professor Wilson, for this great presentation. Our next speaker is Professor David Fisman he's an epidemiologist at the University of Toronto at the Faculty of Public Health, and his presentation is entitled Risk Gradient Modeling and Border Restrictions. So, la parole est à vous, Professor Fisman.
Sorry to be an underperformer. So first off, thanks so much for. I'm a relatively late addition to your group, and honored to be here and excited to be here, and have learned a great deal already today. So I'll pick up where we've left off on models as tools for managing uncertainty, which I think is probably one of their more appropriate applications, and talk about how we think about borders as modelers. I'm not a lawyer. I'm not an international scholar, so I'm a little bit of an outlier. And I also seem to struggle with basic technology. There we go. All right. So when we think about disease and movement in time and space, we can think about it in a few different ways. If we go back to the 19th century, there was a novel disease described by physicians with the British East India Company in 1817 in Bengal, which cholera morbus was the catch-all for diarrheal disease. They called this the Asiatic cholera because they'd never seen anything like it, where people would sort of very dramatically poop themselves to death in a matter of hours. With expansion of trade and travel, cholera broke out of the Ganges River Delta area, where it's native to that area, and moved along the old Silk Road through Central Asia, causing outbreaks in Astrakhan by the early 1820s, moved up into Russia by 1830 or so. It was at this time thought to be a communicable disease. Tsar Nicholas I famously called out the army to stop the advance of cholera. They imposed cordons sanitaires along the roads to keep cholera out. Cholera broke out in St. Petersburg anyway, but along with the cholera outbreak came famine and civil unrest because they'd blocked the movement of trade and commerce. So the idea that cholera was communicable fell into disrepute. Treating it that way had caused nothing but chaos. It got to the Hanseatic League cities along the Baltic, made it to England, Newcastle and Sunderland by 1831. This is a picture of St. James Cathedral in Toronto, where I live. I do like this quote from Joseph Conrad, they said Marlow has also been one of the dark places of the earth. So there are about 3,000 people buried under the parking lot of St. James Cathedral, which is at corner Church and King, I guess. There's no marker. But when cholera hit York, as Toronto was then called, people had no ability to deal with the threat. And our local Ayatollah, Bishop Strawn, who was sort of a local theocratic strongman who was the power behind the throne, took charge of matters. And because the Anglican cathedral was his turf, made the decision that we would have a plague pit behind the cathedral, and that's where those people still rest. There are some other cholera burial sites that pop up periodically in Toronto with construction. For example, if any of you, Bathurst and Adelaide, there are some more cholera graves that have popped up. At any rate, this is a map made by my colleague Ashley Chute, looking at from England, of course. Irish migrants got on a ship to come to the New World, to Quebec City, and they brought cholera with them in the summer of 1832. And you can see how cholera moved through North America. And what it's doing here is it's very sequentially following the superhighways of the age of the 1820s and 30s, which are rivers, lakes, and newly constructed canals. That canal moving across New York State is the Erie Canal, which was finished in 1825. So very clearly a linear diffusion based on travel routes. Now these data come from a report by a guy named Louis Beck, who was a physician commissioned by the New York Governor Throop to look at cholera. And Louis Beck looked at the sequential movement of cholera down trade and travel routes and came to the conclusion that it couldn't possibly be communicable, which is a little bit silly to look at in retrospect, but he came up with all sorts of explanations as to why the individuals who'd had cholera were morally deficient and so had been stricken by this miasma. At any rate, go ahead. So that's really, if we think about a disease moving down a road, that's diffusion in one dimension, right? We can just put that on an x-axis. We can add an x-y, we can add a second axis and have diffusion in two-dimensional space. We can talk about disease diffusing along an x and a y axis. On the left, we have an example of this West Nile emergence in the Western Hemisphere in the early 2000s, sort of a wave moving across the United States. On the right, we have a graph of diffusion of Black Plague in the 14th century in Europe. And I believe Noble was the first person to say, hey, this looks a lot like dropping a drop of ink into a beaker of water. You know, you'd expect to see the density of the ink is going to diffuse through the substance it's been dropped into. We can use the same math, and he used partial differential equations to look at both local transmission of plague and how that plague frontier moves. We can add additional complexity. In the interest of time, I'm not going to talk very much about this, but another way we can model the movement of disease in space rather than modeling it as diffusion is we can add explicit network structure, because people don't actually diffuse like ink molecules in a beaker of water. We have very directed connections with each other and with places. And that's just a screen grab from a model by my colleague Nate Osgood, looking at specific network structure and how individuals are connected. Red is, I believe red here is infected, yellow is incubating, I think green are immune. But you can sort of see the same sort of kind of movement of disease through a structured population. When we get to borders, none of this really works particularly well. So as someone who's new to this world, I'm going to consider borders to be natural or constructed barriers that divide space, and the jurisdictional borders then one example of a border, but a mountain range could similarly be a border. They disrupt the movement of people, and in terms of anthropogenic infectious diseases, disrupt the movement of disease in space. And they also define patches. We've heard a little bit about how patches were defined in the European Union that have different levels of immunization, different degrees of investment in disease preventing infrastructure, and different disease control policies. So as modelers, the way we think of this is sort of schematically, these might be 4 countries, for example, these 4 patches, they might be 4 provinces. And I'm going to be in a manner, if any of you are statistically inclined, sort of if you have multi-level models, you think about within group, whatever effect you're looking at versus between group. We do that with disease transmission models as well. So what we've got is within each of these countries, we've got a transmission model, an SIR model, susceptible, infectious, recovered model. And we also have these models, these countries acting on each other in a manner that's analogous to the force of gravity. So if we have 2 planets in space and they're big planets that are close together, they have a lot of gravitational pull. And if we have 2 small planets that are far apart, they have very little gravitational pull. And we can use a gravitational constant in a model like this to simulate how countries influence each other. So here I've made some of the countries smaller and farther, and some of them are bigger and closer, and the small far ones have less gravity than the big close ones. So this is in a nutshell is how you do kind of relatively simple spatially explicit infectious disease models, if that makes sense. This is something we did in 2010. Don't worry about that. This is just for illustrative purposes, the schematic of the model. This was for cholera emergence in Haiti. What we used to look at movement of cholera, it initially emerged in the Artibonite region of Haiti. And we looked at how cholera moved through the country, region by region. We had data at a regional level. So that's how we had to model. And these are just sort of XY plots looking at predicted order of emergence by region versus actual order of emergence, predicted date of emergence by region versus observed date of emergence. And it's pretty good. It's not too bad, but it looks more or less like a line. Now, when I say gravity, big and close trumps small and far, we can think of that in spatially explicit terms as we did with Haiti. But we can also see that there are some exceptions to that. This is a gravity model applied to the United States by Cecile Biboud and colleagues, where gravity is actually defined by connectedness, which is a manifestation of how much air travel there is between places. So New York and Los Angeles have a huge gravitational pull on each other, and flyover country has much less. So even though emergence of a pandemic in Colorado would be closer to California than emergence of a pandemic in New York, the gravity from New York on Los Angeles is still much greater. So take gravities in quotes here. And I'll end by just giving you 3 basic insights that we can pull out of a very simple metapopulation model. If I have time, I'll get through the graphs that illustrate these points, but this is my take home. And this reiterates what Lisa Foreman's already said. Border measures delay but do not eliminate introduction, and they should be viewed in that light. Big and close is more important than far and wee, even if far and wee is where the initial emergence happened. And lastly, seed and soil are both important, but soil trumps seed. Okay. So this is just an illustration. The blue graph is the place where the disease emerged. We can make this, I don't know, we can make this Congo, and this can be Ebola, okay, is the blue graph. And what we're doing is we're imposing progressively greater and greater and greater border controls that reduce the gravitational pull between these 2 countries. And what we can see is the greater the border controls, the more we delay the epidemic. But when the epidemic arrives, it's identical. It doesn't change. The last orange curve is a totally sealed border with whatever the country of emergence is. And the totally sealed border doesn't prevent emergence. Why? Because there are 4 countries in this model. So it may not come from the country of origin, but it'll just come from one of the third countries. We can see that the size of the country in which the disease emerges, or the closeness or the connectedness, is also important. The orange curve is our baseline in terms of emergence in our home country. The purple curve is if we make the country of emergence bigger. emergence in our home country is sooner. The blue curve is if we make it smaller and farther. Emergence happens later. Big connected places are very important and change disease dynamics for everybody. So there are overlaid purple and red curves there, which is the timing of emergence with and without border controls. When in country 2, we have country of emergence is country 2, we have disease emerge there, we impose some border controls on country 2. In fact, there's a very large country in our network, a China or a Brazil, that is a third country where the disease didn't emerge, but we impose border controls on country 3, this large third country in the network, and we actually get a lot more delay in introduction than by imposing restrictions on country 2. And lastly, seed is more important than, no, soil is more important than seed. Oh, good Lord, that's backwards. Soil is more important than seed. And I'll end with this. What we can see here is that yellow curve is an explosive outbreak in the country of emergence with a very high reproduction number. Blue was our baseline. And then what we see is the yellow dashed line is emergence in our home country. It happens a bit sooner if there's an explosive outbreak in the country of emergence, a bit later if it happens in a country with a lower reproduction number. But the epidemic in our home country is identical. It's just delayed a little bit. Similarly, we can actually have a country of emergence. That yellow line that's sort of going down towards the x-axis is emergence in a country that has a reproduction number below 1. So it never actually emerges, or it emerges and is controlled. Again, there's no difference really meaningfully in what that does to third countries that have imported cases. And lastly, what we can see, and I'll skip this in the interests of time, but just tell you what it shows, is that having your own house in order, having a lower reproduction number internally in your country makes a lot more difference than sealing borders. And we can think of this as fits with some existing models of disease emergence, but we can see examples of soil trumping seed in cholera in Haiti in 2010, Zika in the Western Hemisphere, where there were a lot of dire predictions about what might happen with Zika. We can actually look at the fact that Zika almost certainly was not first introduced into the Western Hemisphere in 2014, but changing soil because of climate change allowed this disease to explode. And then, of course, we have SARS-CoV-2 emergence in 2019, 2020, what happened in China with control of an outbreak versus once the disease moved to Iran, it became uncontrolled. So I will end with that. Those are my 3 key points. Borders create discontinuities between populations, and border measures delay rather than prevent. Big and near trumps far and we, and soil trumps seed for communicable diseases. I haven't considered borders as a control point for gathering intelligence on what's happening in other countries and for situational awareness in terms of importation of novel strains or variants. That's a topic for another time, but is also important, and that's not covered in my talk. But thank you. Sorry to go a bit over.
Thank you, Professor Fisman, for this very interesting presentation. Our last speaker is Professor Sophie Thériault. She's also Vice Dean at the Civil Law section in this university. Professor Eva Ottawa is also a co-author of their paper, but she was unfortunately, she was not able to be here today. And their paper and presentation is entitled First Nations COVID-19 and the Implications of Spatial Restrictions in a Settler Colonial Context.
Merci beaucoup David, je vais peut-être devoir faire ça. Bonjour à tous et toutes. Hi everyone. So I'm very pleased to be with you today to present our paper entitled, as David said, First Nations, COVID-19 and the Implication of Spatial Restrictions in a Settler Colonial Context. So I would first like to acknowledge my co-authors, Eva Ottawa and Florence Robert, who could not be with us today, but who are my partners in crime in writing this chapter. So throughout the COVID-19 pandemic, First Nation communities in Canada asserted their authority to protect their members from the disease, notably by restricting mobility to and from their lands, by refusing entry to all visitors and non-residents except for essential workers, and by implementing travel bans, curfews, and quarantine protocols. These community-led actions were effective in decreasing and preventing the transmission of the virus within First Nation communities who present a lot of underlying vulnerabilities, as my paper will show today. However, the capacity of communities to develop and enforce efficient COVID-19 measures adapted to their specific needs and priorities have been hindered by numerous institutional and material constraints directly resulting from the legacies of settler colonialism, including the historical and ongoing dispossession of First Nations territories and sovereignty, and the systemic discrimination experienced by First Nation people in accessing essential services and goods, especially on reserve. So our paper reflects on the unique implications of spatial restrictions adopted in response to the COVID-19 pandemic on First Nations, with the purpose of assessing how to protect vulnerable community members against the virus while mitigating the cultural, emotional, and economic impacts of barrier to mobility in that context. We argue that the recognition of Indigenous peoples' inherent jurisdiction to protect their communities, lands, and territories according to their own laws, along with the effective implementation of structural changes to address existing and long-standing social inequalities for First Nation are necessary parts of the equation. Moreover, beyond enabling First Nations to respond efficiently and adequately to this and future pandemic, we propose that such transformative changes are necessary steps for Canada to honor its commitment to implement the United Nations Declaration on the Rights of Indigenous Peoples. So, am I at the right place? First Nations communities across the country adopted various measures tailored to the unique needs and circumstances to contain the spread of COVID-19. So these measures largely mirrored those implemented by federal and provincial governments, although very often taking a stricter form. So for instance, many First Nations declared a state of emergency and adopted stringent COVID-19 protocols and bylaws, including lockdowns, quarantine, curfews, and travel restriction in and out of reserve. Alike many countries and infranational jurisdiction, as we saw on this panel, several First Nations erected checkpoints to control access to their communities by non-residents, including shoppers, tourists, recreational hunters, and cottage owners, among others, and smokers, as you can see, who desired to go to the communities to buy their goods. So First Nations grounded their measures in various sources of state law, Indigenous law, as well as international law. So many band councils grounded their measures in the Indian Act, Section 81, that provides that band councils can adopt bylaws to provide for the health of residents on the reserve and to prevent the spreading of contagious and infectious diseases, or based it on their treaty or land claims agreements. But many other First Nation communities, or many First Nation communities, have also anchored the responses in their inherent jurisdiction and legal orders, often referring to Section 35 of the Constitution Act 1982 in their right to self-determination recognized by UNDRIP. So, as argued by researchers and authorities, First Nations communities are best positioned to make laws and take measures in response to COVID-19 that would protect their most vulnerable citizens while considering the unique circumstances, needs, and priorities. However, First Nations responses to the COVID-19 pandemic, especially measures aiming to control access to their territory, have been hampered when not undermined by government's actions and inactions. So, keeping with usual colonial practices, federal and provincial pandemic measures were applied to First Nation communities very often without consultation or consent. So these dynamics resulting from provincial and federal governments' lack of communication and coordination with First Nations became particularly visible when state authority unilaterally decided to reopen their economies without taking into account the systemic barriers faced by First Nations and their COVID-19 measures already in place. So some examples, and there's more in the paper, are hunting and fishing in BC, for instance, declared as essential services. Same thing for mining activities that have been declared as essential services in many provinces, imposing on First Nations living close to provincial parks or to mining operations to coexist with visitors and workers. In a similar vein, some communities, and I'm thinking about the Mohawk of Kanasatake, for instance, to take a very widely documented case, had a really hard time keeping visitors as they could not count on police to help them enforce their checkpoints. And while the mayor of Oka, the neighboring city, was threatening to launch a lawsuit saying that these were blockades and were illegal and detrimental to Oka's municipal economy. So overall, as remarked by my colleague Amy Croft and our co-authors in their chapters in Vulnerable, First Nation communities will continue to face challenges from those who do not respect their inherent jurisdiction, particularly if their pandemic and recovery plans are not coordinated across jurisdiction. So other obstacles, so the efficiency of the mobility restriction measures adopted by First Nation communities in response to the COVID-19 pandemic was also limited by insufficient or otherwise effective institutional and material support from provincial authority. So for instance, while the federal government provided significant financial support for First Nations pandemic response, First Nations communities reported that the funding opportunity did not adequately meet their needs. In addition to creating a heavy administrative burden, especially for small communities with limited capacities, what has been aptly termed by some researchers as colonialism by paper cuts. Furthermore, some provinces failed to meaningfully support the implementation of First Nation jurisdictions, and in some cases to recognize their authority altogether. So due to the lack of enforcement capacity within communities, many First Nations sought to collaborate with provincial and federal partners for enforcement. However, First Nations were often ignored by state authorities or refused to provide any assistance, sometimes insisting that bylaw enforcement is the primary responsibility of band council. All of that while police were enforcing federal and provincial measures on Indigenous peoples and other citizens. So moreover, First Nations across the country denounce the insufficient and fragmented data sharing practices regarding infection rates that impeded the ability of First Nations communities to aptly respond to the pandemic. So this reluctance of governmental authorities to share COVID-19 data with First Nation authorities as governments undermined their ability to plan appropriately and timely for pandemic measures that would be adapted to the changing level of infections. 5 minutes. So another beyond these obstacles to the exercise of Indigenous jurisdictions within the communities, the capacity of First Nations to efficiently implement their COVID measures was limited by the material conditions in which they live, and the health crisis that is already in place, resulting from historical and ongoing colonial and discriminatory laws, policies, and practices. So these pre-existing conditions exacerbated the vulnerability of First Nations, both to the virus, but also to the containment measures implemented either by federal, provincial, or First Nation authorities. So we all know about the housing, the lack and the housing crisis in place in many First Nation communities, and the lack of infrastructures, for instance, to implement quarantine measures. So many communities had to have their members quarantining outside the communities, very far from their family and kin network. The lack of health center and hospitals near, within or near Indigenous communities had for consequence that Indigenous peoples needed to receive treatment very often far from home and from their community networks. The lack of access to essential goods in communities was also a big obstacle to implement fairly COVID-19 measures. So there are examples, for instance, of 8 women in a Northern Cree community in Manitoba who were criminalized for going outside the community and getting diapers and milk in a context where goods were direly lacking in the community. I'm trying to go too fast, sorry. Very out of breath. Okay, so all of these pre-existing conditions that have been existing for very long impeded the capacity of Indigenous communities to implement efficiently COVID mobility restrictions measures that were necessary to protect their own members. So I'll just, because time is up, looking forward to what we can do to address this situation, we propose that that UNDRIP provides a roadmap for the Government of Canada to respond efficiently and adequately to the public health crisis that requires deep structural changes to decolonize the relationship between the Canadian state and Indigenous people, and to address comprehensively the systemic inequalities in governance services for Indigenous peoples. So Canada committed in 2021, in the midst of the pandemic, to implement the United Declaration on the Rights of Indigenous Peoples in Canadian law, which provides for the right of Indigenous people to self-determination, as well as the rights of Indigenous people to healthcare services, equitable access to healthcare services. So I won't have time to go through all of this, but I'll Okay. Okay. So the capacity of First Nations to respond to the health crisis hinges on the recognition and respect for their inherent jurisdiction to protect their communities and traditional lands, territories, and resources in light of the right to self-determination and to free, prior, and informed consent affirmed in the UN Declaration. So I will here just cite the word of the Truth and Reconciliation of Canada that affirms that self-determination holds the key to better Aboriginal health by allowing communities to develop programs that are suited for their own needs and to do so in a holistic way, avoiding the jurisdictional disputes that have plagued progress in health and so many other areas where the residential schools still cast a large shadow. But ultimately, for First Nations to respond efficiently to public health crisis without unduly affecting their citizens who cannot fulfill their essential needs within the community, it is urgent for the state to remedy without any further delay the systemic discrimination experienced by Indigenous peoples in the healthcare system, as well as in the access to essential services, infrastructures, and goods, especially on reserve. In that regard, the UNDRIP provide the rights that are necessary and the necessary roadmaps in order to implement these rights in Canadian law. So I'll finish by saying that these rights are no quick or easy fixes, but well-known and long-awaited structural solutions that are necessary for Canada to uphold its legal obligations and to advance towards truly transformative reconciliation. So thank you, and sorry for being so bad at managing my time this morning. I think I had way too much material. Thank you.
You were very good at managing your time. Thanks to you, Sophie, and to Eva and Florence Robert for this excellent presentation on the impact of our government measure on the First Nation in Canada. My role was very easy today. Every one of the speaker has strictly respect their time. So thanks to them, we have time for a question period. So feel free to come to the microphone. I see there's a Colleen. Turn your microphone on. I think it's off. Oh.
Is that better? Oh, here we go. Sorry about that. Operator error. David, it's a question really for you, because the modeling that you're doing conflicts with the modeling that we saw presented from Brenda, and in an obvious way, because you're assuming that it's sequential or isolated, whereas the border boundaries that were drawn in a number of places, although they started perhaps focused on one or two countries, quickly became generalized, so that everybody coming from everywhere had to X, Y, Z, go through quarantine and so on. And so where those countries which seem, at least on the numbers, to be successful, and sub-jurisdictions like Newfoundland and Nova Scotia, the value of buying that time is, of course, the time to vaccinate, if the jurisdiction is lucky enough to have those vaccinations, resulting in, it seems to me, many lives saved. So I worry a little bit about the take home that it doesn't really matter. You're going to slow it down, but comme ci, comme ça, when you're not actually looking at morbidity and mortality.
All right. I don't think there's any daylight between my modeling and Amy Herford's modeling. Amy's actually a former postdoc, and I think we do things in very similar ways. I think what you see is I've not had the countries in my model do anything with that time that they've bought. And I think that's the key difference with a place like Newfoundland, because Newfoundland wasn't just doing things at the border. They also had exemplary public health controls in place in province. Particularly, they use tools like closing down highways between different jurisdictions to basically cut patches off until disease had subsided. I mean, I'm not in Newfoundland, so hopefully what I'm saying is the truth, but this is from media sources. It was a very aggressive response to cases that did get in, to clusters that did start up, to sort of isolate those off and use best practices to shut those clusters down. So I think had they not had that, Amy's model would have looked like our model, which is you just would have delayed it a bit and the same thing would have happened. I'm not a big fan of border controls, partly because I think that what they do, and I think New Zealand is similar. You know, it's not just that New Zealand controlled its borders. It's that New Zealand was a country with excellent public health practice inside New Zealand, as was Australia. I think on issues that have been very contentious in Canada and remain contentious, like aerosol spread of SARS-CoV-2, both New Zealand and Australia were way ahead of us. And indeed, Australia got a lot of their initial data from their quarantine hotels, you know, things blowing down corridors. So I don't think it's one or the other. I do think it's problematic that folks say, well, we'll just shut the border with this country. And echoing what Lisa said, the focus is usually on the wrong country. And I mean, we see that with phylogenetic data in Canada. You know, you can, I know the National Post tends to have a field day with, oh, we should have shut our border with China. Well, our epidemic came from the United States. No, you know, based on phylogenetics, the Eastern Canadian epidemic originated in New York State. Nobody was talking about shutting off a border with New York State. So shutting off a border with China would have been meaningless. So I do think we tend to overemphasize, and we tend to underemphasize creating conditions within countries that shut transmission down. And I think we tend to underemphasize the degree to which emergence in countries which may themselves be able to control threats are a direct threat to countries that don't have strong public health infrastructure, particularly things like water and sewage infrastructure, with Haiti and cholera being a case in point. You know, here you had a country that had no cholera for 80 years, and other countries introduced it, and you know, it was dry tinder because of the conditions in country. And I think we very much underemphasize that. Sorry for the long answer.
Hi, thank you. I live in London, United Kingdom, so we come at the very bottom of the league tables for this, for comparing efficacy. I wanted to actually pick up on exactly the same question and point that was just made, without saying everything again. I wonder whether the conclusion that we're invited to arrive at, that border controls don't actually matter that much, doesn't follow from the evidence given, because you're looking at infection rates rather than mortality rates. If, as far as I can tell from the studies that were put up in the slides earlier.
Not in mine.
No, not in. So then we know that border controls are associated with lower mortality in a number of cases, not least because of widespread vaccination and so on. So are you saying that the studies that were put up in Professor Foreman's presentation and in your own work have showed that there's no impact on mortality, excess mortality, whose figures, the reliable figures for which I believe are only just really coming into the picture recently?
I haven't looked at mortality at all. And one of the nice things about models are pretend, right? I mean, I can go to the hobby store and buy a model battleship, which I can assemble, turn around in my hands, look at, get insights into what a real battleship does. But if I wanted to take it out on Lake Ontario, it would probably end badly for me. And certainly if I wanted to take it and invade another country, it wouldn't work very well. So I think what models are is they're simplified representations of reality that we can control, that allow us to tease apart. When you look at the responses, the relative success of different countries, I think you look at a country like Japan, which has had very low mortality. I don't actually know what Japan has done in terms of borders. I know Japan had some struggles with COVID around the Olympics. You know, they had a surge after the Olympics, but things then settled down based on very much within country approaches to infectious diseases, which particularly normalized for their population structure, which is much older population than ours, have been far more successful. They've had an order of magnitude lower mortality than we've had, despite having international events and introducing disease. And I think if you look at some of what's sort of emerged both culturally in terms of possibly being a bit of a more pro-social culture, being a masking culture, being a country that was very early to acknowledging airborne transmission of disease, to using tools like posting CO2 levels in movie theaters. They did things quite differently, but they did things differently in a way that reflected transmission inside their country rather than importation.
Yeah.
And I think one of the nice things about a model is you can actually tease these things apart because they tend to all cluster together.
Does your model account for the impact of the location of the epidemic curve across time on possible mortality outcomes?
Well, you could layer that on, but no, I mean, I have people don't die in my epidemic. We
But
don't
I
care.
guess what I'm suggesting is that it's in practice, it's turned out to be absolutely crucial. And so I'm wondering whether there's a potential issue with the model if it doesn't account for the impact of delayed.
I mean, the
transmission.
model. Oh, so you're saying the delay bought time, and
Yeah.
then vaccination could be brought into play, so people died less, and that was the gain associated with that delay.
Yeah.
Yeah, absolutely. If you think that that's what you're buying, then absolutely that becomes a rationale for slowing transmission across borders because you think you've bought some time where you'll be able to do something. I think my point is that the approach seems to be we should close the border, not do anything different whatsoever, probably close the border with the wrong country, and then at some later date reopen the border, and nothing's actually been affected by that if you don't change what you're doing inside your country.
Yes, and that's the seed and soil point. But I wondered if these are so different from one another because the seed is the idea of things crossing borders, and the soil
Right.
is the suite of public health policies to stem transmission. But both are framed with a view to stopping exactly the same thing, which is transmission.
And if you could absolutely prevent introduction of disease, then they would have equivalent impact. But I think with this very simple model, what you can show is that because of third countries, unless you're talking about throwing up a big wall around Canada and cutting off commerce with everyone, which I think in retrospect, if there was a border we should have closed, it was the border with the United States. I think that was never on the table because that would have led to economic catastrophe in Canada. But if if you wanted to actually close a border that would have been impactful in terms of disease transmission, I think there's a tremendous focus. I'm an infectious disease physician by background, and God knows the last 20 years, there have been these efforts on pathogen discovery. I think in the years ahead, we'll learn more about, the role that pathogen discovery and manipulation may have played in the actual occurrence of this pandemic. Entirely seed focused, entirely focused on the bug that's going to cause the pandemic. And you saw this with Zika, with, let's cancel the Olympics because Zika virus will be everywhere. To the absolute exclusion of thinking about, well, is it plausible that this was actually a first introduction of Zika into the Western Hemisphere when we know that other viruses that are transmitted by exactly the same mosquito vectors that come from the same parts of Africa became established in the Western Hemisphere with the slave trade? Over several hundred years, malaria was introduced from Africa with the slave trade and so forth. Is it plausible that another virus that lives in the same mosquitoes didn't get introduced into the Western Hemisphere for hundreds of years? I don't think it's plausible. And yet we were entirely seed focused to the point of people talking about things like canceling the Olympics. Never mind the fact that we don't have competent vectors in most of these other countries. Never mind the fact that it's going to move where it moves via, other means. So I do think we have a tendency to be very, very focused on the pathogen rather than internal conditions in countries, is all I'm really saying.
Thank you very, very much.
Thanks.
Thank you.
Sorry.
Do we have time for a last question online and the two others maybe? Yeah, okay. There's one question online, if I may turn online from Professor Catherine Furbeck. I think it's addressed to Professor Wilson in part, and maybe Sophie, you could complete. It's addressed to the constitutional lawyers. So the question is to what extent did the ability of Atlantic provinces to close their borders with impunity set a precedent establishing ownership of borders by provinces vis-à-vis Ottawa? Did the federal government request standing in the Newfoundland's Taylor case at all? And if not, is their silence remarkable? Oh, yeah, okay. So we'll take the other question and you will be able to answer. Thank you.
Hi, my name's Natalie Brender. I'm with the Canadian Public Health Association. I also have a question for Brenda Wilson about lessons learned from the Newfoundland and Labrador experience. You mentioned briefly in passing the importance of public health competencies as it related to the leadership that was exercised by the Chief Medical Officer of Health. I wonder if you could say more about what you think the Newfoundland experience showed about what the competencies should be for public health leaders to make good decisions and to be perceived as having the authority to make good decisions in contexts where science comes up against economics, politics, and law in the way it did in Newfoundland. What are the takeaways?
Thank you, Natalie. That's a zinger of a question, really, isn't it? I don't have much time to answer it. I would say that the competencies that are required are those that are already outlined, and they are about scientific competencies on the one hand, but also about those that go with leadership and decision making. So I'm not going to articulate all of these, but people can look them up, and I think we understand what they are. What really struck me about Newfoundland and Labrador, and having watched this pandemic with a change in leadership, political leadership, is that at the very beginning of this pandemic, the Chief Medical Officer of Health was allowed to provide the leadership by the Minister of Health and by the Premier of the province. And so for months and months and months, for the longest possible time, what you saw was science and decision-making was allowed to take place the way that one would hope it would happen with in public health, in this kind of public health crisis. I'm aware that this is being recorded, but I would say that there was a definite shift that happened when there was a shift in the Premier. But I will also comment that the whole thing was evolving anyway. So it's really hard to pull out, but I would go back to say that the leadership skills are the critical ones, but you have to be allowed to exercise those, and people have to take the advice that you want to give. I think that's my best answer.
Yes, I'm sorry to. Désolé, I wasn't a speaker today, but I'm a constitutionalist. I wrote a paper or two about the jurisdiction between the Parliament and the provinces on borders. So time is short, so I will be very brief. I will say that the control of boundaries in Canada, the international boundaries and the intra-boundaries, if I may say, is an area of shared jurisdiction between the Parliament and the provinces. Of course, if there's a contradiction between a province's decision and the Parliament decision will prevail. In this, I don't think that the Canadian government or the Attorney General of Canada did request standing in the Newfoundland's case, but it's not. Ce n'est pas juridiquement très pertinent, but the Premier Trudeau and two of its ministers publicly agreed with what provinces did when they closed their borders. So they did not oppose, and they publicly said that provinces can do that. So I think they were agreeing with what provinces did when they closed their borders. Thank you.